Welcome to Session 4 of Pulmonary Academy. This session will review the broad topic of COPD. Let's start with Part A, Overview of COPD. Let's pause for a moment to see where this session fits into the Pulmonary Academy. In sessions 1 through 3, reviewed the background pathophysiology and the approach to the patient in the office visit, and in subsequent sessions, we'll look at other lung diseases and then some miscellaneous topics to finish the course. Once again, let me share a little bit about myself. I'm a board-certified specialist in internal medicine, pulmonary medicine, and critical care medicine, and have been in practice in the Baltimore, Maryland area since 1991, with a focus on teaching and training medical residents and students. An overview of my bio is listed here. Learning objectives for this session include reviewing pathophysiology of COPD, discussing the types of COPD, utilizing and interpreting testing to evaluate COPD such as PFTs and imaging, and learning how to develop appropriate treatment strategies to improve overall function and reduce symptomatology in your patients with COPD. First, let's go over the working definition of COPD, which has been put out by the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD Steering Committee. COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. They have a website on the internet, goldcopd.org. The chronic airflow limitation that characterizes COPD is caused by a mixture of small airways disease, such as obstructive bronchiolitis, and parenchymal destruction, as seen in emphysema, the relative contributions of which vary from person to person. Chronic inflammation causes structural changes, small airways narrowing, and destruction of lung parenchyma. A loss of small airways may contribute to airflow limitation and mucociliary dysfunction, a characteristic feature of this disease. So let's go over types of COPD. Chronic bronchitis is the main type in smokers related to cough. In chronic bronchitis, we have chronic productive cough for at least 3 months for over 2 years or longer, where other etiologies of cough are excluded. We don't include chronic bronchitis in COPD if there is no airflow obstruction. Emphysema is a pathologic diagnosis. It's defined as permanent enlargement of air spaces beyond terminal bronchioles accompanied by airspace wall destruction without significant fibrosis. Even though it's pathological diagnosis, we are able to diagnose this clinically because there are so many good correlates to emphysema that we almost never look at pathology. We'll go over those correlates in future talks. We also exclude emphysema from COPD if there is no airflow obstruction. Asthma is a separate topic and on occasion is part of the COPD spectrum, but many patients, asthma stands alone and we don't include it in COPD. If it's completely reversible, we'll exclude asthma from COPD. You'll see that better in the next slide. There is asthma COPD overlap syndrome, which I'll show you soon, has recently been renamed to ACO, just asthma COPD overlap. Now, I'd like to review the classification of COPD because there is sometimes quite a bit of confusion about the nomenclature. First of all, as you can see here, there is significant overlap between the two most common forms of COPD, chronic bronchitis and emphysema. Although we frequently see patients, usually smokers or exposures or ex-smokers, with chronic bronchitis and no clinical emphysema, or vice versa, the majority of our patients with smoking-related COPD have at least some chronic bronchitis and at least some emphysema. This may be due to a degree of smoking exposure or to genetic susceptibility. Now, you will be seeing in my coming asthma talk that in some patients there is significant overlap between COPD and asthma features. As I mentioned, this was previously referred to as ACOS, or Asthma COPD Overlap Syndrome, but is now termed Asthma COPD Overlap with the word syndrome removed for reasons I'll discuss in the asthma talk. Nonetheless, if we put a box in the middle of the diagram to show only patients who have obstruction, we'll see that there's a subgroup of patients with quite a bit of overlap here. First of all, in the blue area are patients with classic COPD from usually smoking with chronic bronchitis, emphysema, or overlap of the two, but there is an area in the middle with asthma which overlaps with all of these and is part of asthma COPD overlap. Now, what makes this interesting is outside of the square box, I'll point to that right here, there are patients with emphysema who have clinical emphysema. They might have emphysema on their x-ray. They might have emphysema by lung function with low diffusion capacity, but they do not have obstruction. And patients with emphysema with no obstruction are usually left out of the COPD syndrome. Likewise, a smoker with chronic bronchitis who has no obstruction has chronic bronchitis, but we leave them out of COPD. And finally, most of our asthmatics reverse their obstruction, and we do not call them COPD, but an occasional asthmatic who always has obstruction will be part of the COPD spectrum. So let's look at the scope of the problem. Globally, 384 million people were involved with COPD in 2010. 3 million people died of COPD globally in 2012, representing 6% of all deaths worldwide, the fourth leading cause of death. In the United States, COPD is the third leading cause of death. There's about 120,000 deaths a year in the U.S. from COPD. We expect the COPD epidemic to worsen over the next 30 years due to ongoing exposure to COPD risk factors, not only increasing smoking worldwide, but also other environmental factors such as worsening pollution, the aging population, and by the end of the next decade, we expect COPD will be the third leading cause of death after cardiovascular disease and cancer. So how about the social and economic burden of COPD? COPD causes increased morbidity. This can be measured by the disability-adjusted life year, which is years of life lost plus years of life with disability. In the United States, the only thing that causes worsened DALY is ischemic heart disease. Annual cost in the U.S. is $32 billion direct, and there's an additional $20 billion of indirect cost, such as lost productivity at work. COPD exacerbations account for the largest proportion of the burden of COPD on our society from a financial standpoint. These patients go into the hospital regularly and use a lot of resources. Here's a map of the etiology and pathology of COPD taken from the GOLD Initiative. Frequently, the etiology is a combination of environmental and patient factors such as smoking and pollutants, as well as patient predispositions such as genetics. There's pathobiological factors such as impaired lung growth, accelerated decline, lung injury, and systemic inflammation. Pathology occurs at the level of small airways, and we can see emphysematous changes. And then this leads to both clinical manifestations and airflow limitation, and these tend to go hand in hand. When airflow limitation worsens, clinical manifestations tend to worsen. Now, this is a very well-described graph that's been around since the 1970s, the Peto-Fletcher graph, we refer to this. What it shows is we all lose lung function with age. We start out at expected at about age 25, let's say 100% are predicted, and as we age, we lose our lung function, and for that reason, we have to set our PFT normals based on the patient's age, because we know the predicteds go down with age. Now we see some smokers who stay on this normal curve. They smoke and they have a normal rate of decline of lung function. In this graph, we're showing FEV1. Other smokers are susceptible to smoke and they have an accelerated loss of lung function. Now when they quit smoking, they'll continue to lose lung function, but that's at the normal rate of decline. They're not immune from lung loss. And if they were to continue smoking, they'll predictably have a rapid and ongoing accelerated loss of lung function. So we do sometimes see people right over here who tell me they're out of breath. I diagnose COPD, and they say they don't understand how they got COPD. They quit smoking when they were 50 years old. Right over here. And we'll say, well, when you quit, you had no symptoms, but you started to have emphysema or COPD changes, and then the natural progression of COPD caused symptoms later on in life. Had you not been a smoker earlier in life, you wouldn't be seeing me in the office. Now, the decline of lung function in accelerated loss reaches thresholds, so at about 50% or 60% of FEV1, most patients are symptomatic. Symptoms worsen as the FEV1 goes down to 30%. We define 30% FEV1 as severe obstruction, as I'll show you in a few slides, and we use that because that's when severe disability sets in. And then when the FEV1 goes much below 20%, patients actually can succumb to COPD. So what are the symptoms of COPD? Obviously, dyspnea, especially with activities. It's very important when we take a history to really pin down the degree of activities causing dyspnea. A lot of our patients say that they're just not that symptomatic, but we find out on close questioning that what they've done is they've learned to slow things down, become very inactive and sedentary, and at their new, very low-level activities, of course, they're not too symptomatic. But if you push hard, you find out that if they try to do what they used to do, they're quite out of breath. Cough, sputum production, and they have acute exacerbations, as you'll be hearing about and as I'm sure you've all seen. Symptoms are worsened by concomitant medical problems that frequently coexist with COPD, such as cardiac disease, obesity, vascular disease, physical deconditioning, and I should mention sleep apnea. Physical findings of COPD include, on visual inspection, barrel chesting, which is an increased AP diameter where their sternum is literally sticking out in 3 dimensions right towards you. It's actually hard to miss once you get used to seeing barrel-chested patients. Tripoding with palmar and arm extension surface erythema and calluses. The patients actually lean forward and put their palms onto a table or onto a support, onto chair arms, and they push down to sort of get some mechanical advantage with their accessory muscles. Tachypnea is defined as a rapid respiratory rate. It's actually not the same thing as dyspnea. Dyspnea is symptoms of breathlessness. So we sometimes see those two words confused. Tachypnea is a sign. We count how many breaths per minute. Dyspnea is a symptom. The patient tells us that they're breathless. We could see use of accessory muscles from sternocleidomastoid retractions to intercostal retractions. Pursed lip breathing either is a natural response to COPD. Some people believe, although it's not clear, that this is a natural reflex to create some auto-PEEP or some back pressure to help keep the airways open. What you're doing there is you're exchanging auto-PEEP. I said that wrong. Some people believe that this is an effort to create extrinsic PEEP to dissipate some of the auto-PEEP. By creating some extrinsic PEEP by blowing against pursed lips, you raise the airway pressures up during exhalation and you dissipate some of the intrinsic pressure that's building up in the alveoli. Cyanosis is a blue discoloration of the skin. I have to tell you, hardly ever see that in clinical practice, but of course in an acute exacerbation before you intubate someone, that might be the most obvious sign. Something I've learned to look for, which I do see on occasion, and I check on every patient in respiratory distress, is conjunctival injection. Acute hypercapnia is a vasodilator, and we'll see the conjunctiva become beet red. I didn't mention it here, but as long as I'm talking about acute respiratory failure, I find the most reliable sign in my practice to decide if someone's okay or needs intubation is abdominal paradox. Normally, when we breathe in, our abdomen moves out, and if someone's in distress and they're breathing in and their abdomen is sucking inward, then that means their diaphragms are moving paradoxically upward, which is diaphragm failure from fatigue, and that means they're probably just about ready to be either intubated or have some sort of non-invasive support to get them over the hump. Nicotine stains we sometimes see. I didn't mention on the slide, but more often I just walk in the room and I can smell the cigarette smoke right on the patient's clothes. I don't even have to ask them if they're smoking. It's pretty obvious. Another thing everyone's classically taught is to look for clubbing in COPD, but it turns out that that's extremely uncommon. Clubbing is really a sign of other chronic lung disease or cancer, not so much COPD. These were the visual inspection signs. Let's go on to percussion. We'll see increased resonance, which is a very hollow, ringing sound. Resonance is low frequency, and by percussion, we can also percuss the level of the diaphragm. We just tap on the back as we go down, and we wait for the sound to go from resonant to dull, which is the diaphragm position. And in bad COPD, we'll see the diaphragm are quite low. The lung resonant sounds go all the way down, almost to the level of the pelvis. Once we know where the diaphragms are, we can have the patient take a deep breath and hold it and remeasure the position. Most frequently in advanced COPD, there's almost no movement at all of the position. So the diaphragms are really already maximally pushed down. When someone takes a deep breath with bad COPD, they can't bring them down any further. We see no excursion, or at least decreased excursion. On auscultation, we'll hear wheezing. Sometimes the flow is so bad we simply hear quiet, distant breath sounds, and the heart tones can be distant in patients with COPD because there's so much air between the heart and the stethoscope. Let's review risk factors for COPD. Obviously, smoking is clearly the number one risk factor, and there is a dose-response curve. We measure smoking in 1 pack year. I think everyone knows how to do it. You multiply the average packs per day times the number of years, but you might not have realized that a pack year is actually a quantity of cigarettes. So 1 pack year means someone smoked 1 pack per day for 1 year. Since there's 365 days in a year and 20 cigarettes in a pack, that's 7,300 cigarettes for pack year. So for example, if someone smoked 1.5 packs per day for 40 pack years, they've smoked 60 pack years. Just multiply 60 by 7,300, you realize they smoked almost 500,000 cigarettes. Here's a fun fact. 137 pack years is exactly 1 million cigarettes. Other risk factors are biomass, fuel exposure, and air pollution. Host factors such as genetic abnormalities. The most commonly one recognized that we've identified is alpha-1 antitrypsin deficiency, which we'll discuss later, but we're pretty clear that there are other not yet identified host genetic abnormalities because we see familial COPD in the absence of alpha-1 antitrypsin deficiency. It just means we haven't identified all of the genetic abnormalities. There are also some congenital abnormalities of lung development that can lead to risk for COPD. Aging is a risk for COPD, and males are more prone to COPD than females. Finally, socioeconomic status correlates with risk for COPD. That is, lower socioeconomic status is a higher risk for COPD. Recurrent infections also are a risk for progression of COPD. We used to think you would recover from an infection and get back to where you were once recovered, but now we realize that on average, you leave a little bit on the table with each exacerbation. You don't quite get back onto the curve. So in a sense, preventing recurrent infections not only keeps someone out of acute trouble, but changes their trajectory of their COPD in the long term. Let's talk about pathology of COPD. COPD involves chronic inflammation in bronchial wall changes, especially the chronic bronchitic component. So here's a normal airway. Here's an airway with some luminal encroachment from bronchospasm and mucus, and as it's getting worse, the smooth muscle is tightening around the outside, especially in acute exacerbations. There's more mucus production, and then you get some air trapping where the distal air spaces are holding on to the air spaces are getting enlarged. Now here's some pathology showing thickening of the airway wall, which is this ring here. The epithelium is actually angry and inflamed, and there's debris right in the lumen of a bronchus here. We know this is an airway because there's some cartilage. So here's the pathological changes of COPD. This is really the emphysematous destruction of the air spaces over here. Basically resembles Swiss cheese. Even these are macroscopic changes you can see with the naked eye. In a healthy lung, you really should only see lung parenchyma that looks like a sponge, but you really shouldn't see much in the way of macroscopic holes in the lung. Now here's the normal chest x-ray. On the x-ray we see the heart, normal size. Lung fields are not quite black, but pretty clear. They're radiolucent. They let the x-ray through. And we see very clear round diaphragms. And the parenchyma is just an off black shade of gray. On the lateral view, we'll see the heart is anterior. Diaphragms are seen from the side. And the spine, as you go down, you're looking through more and more lungs, so it seems to be a little bit blacker down here, but it's not overly black. Now let me contrast that with a COPD patient. So this is a patient who has extremely tall lungs. When we count the ribs, it's hard to see, but the first rib goes right around over here. I'm going to keep going over until you see it. Then this one's the second rib already. So this is already the third rib. And let me count. 4, 5, 6, 7, 8, 9, 10, 11, 12. So the diaphragms are at the level of the 12th rib. We see some very faint lines, which are the edge of bully. Here's a line over here around lucency. You can sort of see circular, what we call curvilinear densities. Here's one right over here. Here's one over here. One more right over here. So these are all the edges of bully. The next thing you notice is the top half of the lungs have almost no lung parenchyma, just a big black void of no lung. This is all bullous destruction of the lung in the apices, and in classic emphysema, we'll know that the bullous or emphysematous changes predominate in the upper lobes and relatively spare the lower lobes. This is where the patient's lung function still remains. Now, a lateral film shows increased lucency behind the sternum. Here's the sternum. This is the retrosternal space. I'm going to show this to you in a minute side by side with the film I first showed you. And then flattening of the diaphragm. So this is a healthy patient's lungs, just to give you a frame of reference. The parenchyma is sort of a dark, not quite black, but a darker shade of gray. And in between are the branching blood vessels. And everything is, just get used to this. This is a normal CT scan. Just for fun, I wanted to see if you saw anything unusual about the CT scan. A lot of these pictures that I don't give, let me say, all of the pictures I use that I'm not going to give credits to are from my own teaching files. And this was a healthy person, but I don't know if you noticed in his right main bronchus, this is the right main bronchus, this is the left bronchus, this is actually the left upper lobe bronchus when it came back around here. There's a very dense round lucency with a hole in the middle, and this wound up being a cherry pit that this patient had aspirated. We had to use a basket to extract this out of the patient's right lung. Thought that would be a little interesting twist to this slide. But forgetting about the cherry pit, this is what normal parenchyma looks like. So I'll let you take a look at it for a minute, get an idea of the coloration of the lung. It's not black, it's sort of an off black, sort of a dark gray. It's not too white either. Okay, contrast that with a patient whose CT might have matched the X-ray I showed you a minute ago with the bad emphysema. This patient has almost no healthy lung. In this area, right down here, is maybe some functional lung that has some health to it. Maybe not perfect, there's still a little emphysema, but that's the only part of this slice. Now, in a patient like this, if we were to slice closer to the diaphragms, it wouldn't be quite this bad. We're still in the mid-lung position. What we see are along the surface of the lung, there are what are called blebs. They're surface bulli, and within the parenchyma of the lung, we actually see bulli, which are bullous changes. Okay, these are large blebs, bulli. Blebs and bulli really are just by location more than anything. There are bullous changes right into here. There's really virtually complete destruction of the lung right where I'm pointing here. Now, if we look at the pathology, we can see these open air spaces. This is the cystic changes of emphysema where there's, I shouldn't really use the word cystic, but the destructive changes here. And what we'll see if you look closely are these objects that are called drumsticks. Right over here, you'll see one right above my pointer, right over here and here. Here's one over here. Those are the remnants of alveolar wall structures that are just moth-eaten away. They stick out like drumsticks. It's where they got the name. This is a nice correlate. We talked about on the surface of the lung are bulli, and this is a pathology specimen of a patient's lung that was removed, hopefully for an operation, like a cancer operation, not an autopsy, but I don't know the source of this material. These materials are actually from a wonderful Flickr site by Dr. Yale Rose. Dr. Rose has his entire pathology collection as open source material that he shares with the world, and he has just the most wonderful collection of pathology to share. So this is how bulli look pathologically. Now there's an interesting pattern that you can see. This is called Paraseptal Emphysema. You'll hear the words used, but there are these little horizontal lines that go from the lung and tether on to the apex of the lung. As the lung is destroyed, it pulls away, but it leaves these strands like this. But what I love about this CAT scan is I was able to match it up. This is one of my patients. I was able to match my patient's CAT scan up against one of Dr. Rose's pathology specimens, and you can see the exact correlation of why it looks like it looks. These are the paraseptal bands in emphysema on a pathologic. And not only does this patient have paraseptal emphysema, but you can also see the emphysematous changes right in the lung parenchyma. These are all abnormal changes. Another subtle finding that's one of my favorites is something called Mosaic attenuation. It's actually not always this easy to see, but in an example I gave an obvious one. You could see this sort of wavy change of color. You have these white areas and these black areas. And you can argue, well, is it that the black areas are the abnormal areas and they're blacker, or are the black areas normal and the white areas are abnormal? And a lot of times it's hard to be sure. Because if it was the case that the black areas were normal and the white areas were abnormal, we would call these white areas ground glass attenuation. However, if we know the patient has COPD and we look at the color gradation in the clinical history, we'll realize that the black areas are the ones that are abnormal. So let's start over. The white areas are normal in here, and then this black area here, the black area here, here. It forms a mosaic pattern, and what these black areas are areas of focal air trapping the extra air, similar to that cartoon I showed you that the alveoli was overdistended, extra air in these lung zones cause hyperlucency. And what's interesting about Mosaic attenuation is if you do the CT scan when the patient's taking an expiratory film, you'll actually make the part of the lung that's connected to the mouth without obstruction even wider as the patient exhales, but these black areas can't change and they stay black. So you'll actually bring out this pattern with an exhalation film, which is sometimes done to help distinguish which is the abnormal area, the black or the white. If the pattern worsens with exhalation, then we know it's a mosaic attenuation and the black areas are abnormal from the air trapping. So what about pathogenesis of COPD? COPD is a complicated disorder. No one pretends that we truly understand all of the pathogenesis, but we believe there's some degree of chronic inflammation, inflammatory mediators, oxidative stress from free radicals, superoxide, peroxide, and the like. And there's almost always felt to be some imbalance between proteases, which are natural chemicals that break down the lung, and antiproteases, which are natural biologic chemicals like alpha-1 antiproteinase or antitrypsin that protects the lung. So the most commonly quoted protease is called trypsin. It's a tissue degradation chemical, and we have a natural ability to block its effect with antitrypsin, which is the most common human antiprotease. Now, patients with advanced COPD can get into some interstitial fibrosis, and just because we see some interstitial fibrosis on pathology does not mean they have a pulmonary fibrotic disorder. Fibrosis is actually part of the spectrum of COPD. So the pathology of COPD involves reduced airflow. This is required for diagnosis. I mentioned earlier that if someone has chronic bronchitis and completely normal airflow, or they have some emphysema but normal airflow, then they do not have COPD. By arbitrary definition, the Global Initiative of Obstructive Lung Disease requires adults to have an FEV1 to FEC ratio under 70%. By now, I hope you know what we're talking about here because I've already gone over pulmonary function tests, but we look at the ratio of how much comes out in the first second of a forced exhalation to the vital capacity as the hallmark of obstruction. So patients who have a low FEV1 to FEC ratio are obstructed, and 70% is a pretty good cutoff because anyone in the 60s we can be confident is obstructed, assuming it's a good effort. There are people who are obstructed between 70 and 80. It really depends on demographics and age. So a 25-year-old with an FEV1 ratio of 72% is almost certainly obstructed. But for the purposes of simplicity, most COPD patients are middle-aged adults or older, and we're pretty strict. We want them to have an FEV1 to FEC under 70%. There's air trapping, and because the air is trapped in the lungs volumes get very large. Now, lungs and emphysema actually are easy to inflate out of the body because they don't have a lot of elastic tissue left holding them together to resist stretching. But when a lung is super inflated, like a balloon that's inflated, it gets really hard to inflate it anymore. And I have an exercise if you want to pause. If you take a really deep breath and almost with full lungs, try to breathe at normal tidal volumes at a high lung volume, and you'll see how much work it is. COPD patients have excessive mucus production, and pathologically they have excessive goblet cell and mucus gland formation, making all of that mucus. And they can get secondary pulmonary hypertension. Most common mechanism of that is called hypoxic pulmonary vasoconstriction. They're so chronically hypoxic that the pulmonary vascular bed squeezes down the pulmonary arterioles to raise the pressure in a response to hypoxia. It's actually the natural response to hypoxia. It's just very exaggerated in patients with COPD. So the role of spirometry in COPD. So we use spirometry in all patients with COPD that are under evaluation and even in follow-up to diagnose COPD, which is to say we use it to demonstrate reduced airflow, as I just mentioned. We use it to document severity of COPD. I'll show you the gold criteria in a minute. And we use spirometry to guide therapy. It's an objective measure that we use to complement subjective symptoms. The spirogram results influences our decision about the medication regimen, but it never dictates. I'll have people on occasion that have fairly bad obstruction, but they're completely compensated. They do well. They do their activities of daily living, and I don't really push harder on the medications if they're doing well. We make serial measurements over time. That helps us gauge response to therapy and progression of disease. So here's a quick review from my prior talk. This shows a patient in yellow with the flow coming out. Just to remind you, this is time going by, usually at least 6 seconds, and this is the volume. We start a forced vital capacity spirometry maneuver at total lung capacity. We ask the patient to blow out as hard as they can for at least 6 seconds. A normal patient is the white line. By 1 second, they're 70% or more finished. The last 5 seconds is just the tail end. But in a patient with COPD, and this patient has very bad obstruction, at the early part, let's say about 1 second, they have a very low FEV1, and you'll be able to see some of the parameters we look at here. The peak flow is the fastest flow, the steepness of the volume versus time curve. This is a very steep flow. There's a lot of volume change in a very short time. That's what we mean by flow. Delta V per delta T. This is a very slow slope or very flat slope. It's a low peak flow. Just to review from our other talk, a normal spirogram has a high peak flow, and then it comes down to a normal flow in a straight line. A severely obstructed patient has a very low maximum flow rate and severe incoving, which is to say there's extreme flow suppression in the middle volume. As the middle volumes of the lungs come out, the flow is extremely suppressed. Notice how when they're exhaling, the flow is suppressed, but when they're inhaling, they can generate more flow, and that's because exhalation exacerbates obstruction by squeezing on the airways when you're blowing out. Inhalation relieves obstruction intrathoracically by pulling open the airways that had been squeezed closed. So this is a bit of a review from my other talk. In fact, the slide itself was from my other talk, but I thought you'd like to see this slide again when we were actually talking about a disease process, not just in the abstract. So another review, because I want to show you how this is affected by COPD. So to review a normal patient, I had mentioned that patients breathe in and out with normal tidal volumes, just minding their own business. Here it is tidal volume, but from my lung volume talk in my second session, you could see that we all have an inspiratory reserve and an expiratory reserve, so that we take a normal vital capacity, but there's a little bit more that we can't empty out the residual volume. The biggest breath we can take, the vital capacity, plus what we can't empty, the residual volume, adds up to the total lung capacity. So this is a review of where we stand in a healthy person. Now for COPD. So in COPD, see this moved up. The residual volume is much larger. I'll show these to you side by side. So the patients are literally breathing at a very high lung volume. Same exercise. Take a really deep breath in, and without letting anything out, try breathing at a high lung volume. It's not a lot of fun. Now we can see the vital capacity go down compared to the other patient, the healthy patient, but that doesn't mean their lungs are small. Their lungs are quite large because their residual volume is large. Let me show you these side by side. So what happened is, even though the vital capacity is smaller with COPD than a healthy person, the total lung capacity is large, and that's entirely because of air trapping. This patient's residual volume is more than twice as large as it was. This is all of the gas trapped in the lung, so they're breathing at a very high lung volume. Now, to remind you of the most common pitfall I talked about in session 2, but you'll see it one more time. I just don't want anyone to make this mistake. In patients with moderate to severe COPD, like this patient over here, don't assume that a low vital capacity means a patient is restricted. I see this mistake made almost every week. Dr. Sloan, my patient's vital capacity is only 60%, so they have restrictive disease. The answer is probably not. If they have severe COPD, they almost certainly have just hyperinflation, a very high residual volume, and they just can't empty their vital capacity because the air that should be coming out is trapped in their lungs. One more review for my spirometry, my PFT talk is lung diffusion capacity is a measure of how well gas or oxygen, but we use carbon monoxide as a tracer, moves from the alveolar space through the membrane, which separates the alveolar space from the capillary network, into the blood. In emphysema, you've just seen pathology, you've just seen some CTs. You can see there's just none of this alveolar space left. So that's the reason why there's very low diffusion capacity in emphysema and there's gas exchange problems. The membrane, as I mentioned, represents the epithelium, the interstitium, and the capillary endothelium. Diffusion is proportionate to the area and inversely proportionate to the length. In emphysema, we lose a lot of area, and the quality, which is K, of the membrane is down, the intrinsic permeability, making diffusion capacity very low in emphysema. So how do we diagnose COPD? We take a good history, we pay attention to dyspnea, especially quantitating the exact degree of activity of when they become out of breath and how that's played out. One of the things I do, because I do a lot of cardiac patients, I'm the intensivist for our cardiac surgical service, is we see a lot of cardiac patients, and I can frequently distinguish the mechanism or the etiology of dyspnea based on the timeline. Patients who were moderate smokers their whole life and became severely dyspneic over 1 month, that's not the natural history of COPD. That's very worrisome for cardiac etiology of dyspnea. COPD-induced chronic dyspnea usually comes on slowly, not just over months, but over years. We get a good history of cough, sputum production, and wheezing. We look at risk factors, obviously smoking history, secondhand smoke, or environmental occupational factors. We do need to document a low FEV1 FVC. It's actually required to document under 70% diagnosed COPD in anyone. That's just the definition of COPD. And we have to consider coexistent chronic diseases such as cardiovascular disease, obesity, psychiatry diseases, or lung cancer. And what I keep forgetting to put on the slide, but I can never say enough, coexistent sleep apnea complicates a big percentage of our patients. Differential diagnosis of COPD includes asthma, CHF, bronchiectasis, chronic infections, bronchiolitis, or central airways obstruction. There are obviously other things on this list, but these are the big 6. My final slide in this part A is regarding severity of COPD. We actually, for the most part, stick to the Global Initiative of Obstructive Lung Diseases severity scale. All patients with COPD must have a FEV1 to FVC ratio under 70%, as I mentioned, and then we grade the severity as Gold 1 through Gold 4, with Gold 4 being the most severe. In Gold 1, FEV1 is preserved at over 80%. In Gold 2, it's under 80. In Gold 3, which is severe, it's under 50. And in Gold 4, it's very severe. I thank you for listening to Part A of this series, Session 4. This series only has one more part, Part B. That's coming up next. It will be on treatment of COPD. Looking forward to seeing you on the next slide set. Thanks. Thanks for joining me today. If you enjoyed this talk, I encourage you to go to our website, pulmonaryandsleepacademy.com, to learn more about our full course offerings, Pulmonary Academy, which is hosted by me, and Sleep Academy, which is hosted by Dr. Brian Bonner, a nationally recognized expert in sleep medicine. Together, these two courses offer 32 hours of continued education credits. I thank you for your interest in PSA.